Today, we're gonna talk about fusion for lumbar spinal stenosis. Definition: lumbar spinal stenosis is typically caused by degenerative phase joint arthrosis and leads to compression of the nerves, resulting in walking disability and leg pain in the elderly. Traditionally, spinal stenosis is treated with lumbar decompression laminectomy, but in the United States, increasing numbers of patients are treated with fusion in addition to decompression.
My name is Dr. Stefan Prada. I'm one of the orthopedic spine surgeons at the Laser Spine Institute. I'm going to discuss spinal stenosis and its ramifications. Spinal stenosis is, by definition, narrowing of the spinal canal. This is your typical lumbar or low back. Through the middle of the lumbar spine runs the spinal cord. Inside the cord or the nerves, these areas can be pinched as the spinal canal narrows. Spinal stenosis can be caused by various things as we age: bone spurs, thickening of the ligament, bulging or herniated discs, cysts growing from facet joints, arthritis, and inflammation. When it reaches a certain point of narrowness, then you as the patient would begin to experience symptoms. These symptoms can include pain, numbness, tingling, weakness in the legs, pain in the back. Generally, treatment for spinal stenosis can start with something conservative. Some patients benefit from traction or inversion tables, chiropractor, some physical therapy, anti-inflammatory medications, or even epidural steroids that they can get a period of relief or some level of improvement. At some point, spinal canal stenosis will become significant enough that the conservative treatments fail to alleviate the symptoms. And at that point, the patient generally will look for some type of surgical relief from their symptoms. Through minimally invasive techniques at Laser Spine Institute, we can make an incision in the low back that is smaller than an inch. We split the muscle. It is a muscle-sparing surgery. Therefore, the muscle is not cut. Less pain, less bleeding, quicker recovery. We get down to bone and make a window in the bone called a laminotomy. Through that window, we're able to access the spinal canal. We're able to remove offending agents that are pinching or narrowing the canal, thereby eliminating the pinching or symptoms that are experienced by the narrow spinal canal.
Applications in medicine. Performing fusion in addition to bony decompression surgery is generally accepted as the best practice, even in the case of degenerative stable spondylolisthesis, in which the arterially slipped vertebra does not move more than 3 mm forward on the adjacent vertebra below. Previous studies, however, have not shown benefits of fusion over decompression alone for the treatment of stenosis.
The lumbar spine in the lower back commonly degenerates with age, causing leg and back pain. Components of the spine include the vertebrae, lamina, disc, spinal cord, and nerves. With degeneration, abnormal growths called bone spurs can form. There are many causes of low back and leg pain, including spinal stenosis. Spinal stenosis is most frequently caused by the gradual degeneration of the spine from aging and arthritis. Spinal stenosis may or may not cause symptoms. You may feel pain, numbness, weakness, or cramping in your legs. Your symptoms may come and go and vary in intensity. They are often brought on with walking. Many cases of spinal stenosis can be treated without surgery. However, surgery is recommended if you experience severe or progressive nerve involvement, loss of function, and continued pain. Lumbar laminectomy, also called lumbar decompression surgery, is used to enlarge the narrowed areas of the spine. Lumbar spinal fusion restores stability and involves securing a bone graft to the bones in the spine so they will heal together and form one block of stable bone. Let's take a look at the procedure. An incision is made in the middle of the spine at the involved levels. The muscles and tissues are detached from the spine to allow access to the spinal bones. Bone is removed along with thickened tissues and bulging or herniated discs. If the removal of bone makes the spine unstable, the bones are permanently connected to stop movement. At the end of the surgery, a temporary drainage tube may be placed to help reduce blood and fluid collection in the wound. The incision is then closed and bandaged. You will most likely wear a brace for support while your spine heals. Physical therapy will help you strengthen your trunk and learn proper body mechanics for activities. The recovery process is different for everyone. Generally, the recovery time for lumbar laminectomy is a few weeks for resuming light activities and several months for a full recovery. Lumbar spinal fusion has a longer recovery time. Your doctor will let you know what to expect. You should remain as active as possible within your doctor's set limits and adhere to your safety precautions.
Advantage and disadvantage. Advantage. A spinal fusion surgery is designed to stop the motion of the painful vertebral segment, which in turn should decrease pain generated from the joint. Performing fusion in addition to bony decompression surgery is generally accepted as the best practice. Disadvantage. The addition of instrumental fusion for the treatment of the most frequent forms of lumbar spinal stenosis does not create any added value for patients and might be regarded as an overcautious and unnecessary treatment. Fusion leads to increased operating time, blood loss, and length of hospital stay.
Spinal fusion is performed on the spine to weld two or more vertebrae together, using surgical hardware and bone graft material. The spine consists of a series of interconnected bones called vertebrae, extending from the base of the skull to the tailbone. Each vertebra connects with the one above and below at the facet joints, allowing them to move relative to one another. In between each bony vertebra lies a shock-absorbing intervertebral disc. The facet joints and intervertebral discs work together to permit the bending and twisting motions of the back and neck. Protected within the vertebral column is the spinal cord, which connects the brain to the rest of the body. Spinal nerves emanate from the spinal cord at regular intervals. Your doctor may recommend spinal fusion if you have one of the following conditions: a fractured vertebra, excessive motion between vertebrae causing instability and pain, spondylosis, a degenerative arthritic condition that may cause loss of normal spinal structure and function, or spondylolisthesis, a condition in which one vertebra slips forward relative to the one next to it. Other conditions that may require surgery include osteoarthritis of the facet joints, a spinal deformity such as scoliosis or kyphosis, or a bulging or herniated disc which can press on the exiting spinal nerve. Spinal fusion is designed to eliminate movement between the affected vertebrae, making the spine more stable and decreasing pain. Before your procedure, an intravenous line will be started. A catheter may be placed in your bladder to drain your urine. Spinal fusions are done under general anesthesia, which means you will be asleep for the duration of the operation. A breathing tube will be inserted through your mouth and into your windpipe to help you breathe during the procedure. If your surgeon is using your own bone for the fusion, he or she will make an incision overlying your hip and remove a bone graft. If your bone graft is coming from another donor, it will be harvested prior to your procedure. If you're having an open procedure on the lumbar spine and your lower back, you will lie on your stomach and your surgeon will make an incision directly over the spine. If you are having surgery on the cervical spine and the neck, your surgeon will generally approach this area from the front. In some cases, a spinal fusion may be performed using a newer, less invasive laparoscopic technique. Rather than one or two large incisions, a laparoscopic spinal fusion requires several tiny keyhole incisions, through which the laparoscope and special surgical instruments are inserted. Using a high-speed drill and other instruments, your surgeon will remove the disc between the two vertebral bodies to be fused. Next, your surgeon will insert the bone graft into the space between these two vertebrae. He or she may also place a plate and screws over the graft to hold the vertebrae together until they fuse into one bone. To complete the procedure, your surgeon will close the deep tissue and skin incision with stitches. Many surgeons will also place one or more drains beneath the skin that will remain in place for a few days. After your procedure, you'll be taken to a recovery area for monitoring. The bladder catheter will likely remain in place for several days. You may be unable to eat for a day or two after surgery and will receive fluids and nutrition through the IV. Some pain is expected during the first few days following surgery, and you will be provided with pain medication to control it.
Issue applied in Ecuador. So, in these tables, we are going to see the results of the surgical treatment of degenerative stenosis of the lumbar vertebral canal in a private center of the city of Quito. So, in the table number 1, we are going to see the patients with lumbar vertebral degenerative stenosis were distributed according to age and sex. Patients predominate in the age between 16-69 years, with more than 70% of the total sample about 63% were male. In the table number 2, we are going to see the patients who underwent surgery were related by the two types of techniques. It was observed a greater frequency of use of the decompressive techniques, which were applied to 15 patients for 55.6%. On the other hand, the decompressive plus stabilization were performed in 12 patients for 44.4%. Finally, the conclusion. My conclusion is that the patients with lumbar stenosis, even in patients with degenerative spondylolisthesis, the compression surgery plus fusion surgery does not result in better clinical outcomes than those of the compression alone. The post-operative functional outcomes are independent of fusion. Although this conclusion may be true, in practice the patient-specific anatomy should be studied to determine whether a biomechanical predisposition for instability exists.
We reflect the subcutaneous tissue off the fascia with the Cobb elevator. This makes it easier to close the fascia back together. Here we're pre-treating the muscles as we subperiosteally dissect the muscles off the spinous processes to expose the spine. The assistant pre-treats and suctions as the spine is exposed. We're packing a lap sponge into the space to also help in hemostasis. The bovie is used for dissection of the initial fascial layer. The aquamanus is used to pre-treat. This is sort of a tag team approach where the assistant pre-treats to decrease the blood loss from the dissection. Here the assistant is pre-treating the facet articular region, also obtaining hemostasis and pre-treating the vessels around the facet joints prior to dissection and exposure of the facet joint capsules, allowing the surgeon to be more efficient and to concentrate on exposure and to concentrate less on having to achieve hemostasis himself. The wound is packed off and the dissection is carried on the opposite side to further expose the lamina, the ligament of flavum, and the facet joint capsules, and to expose out to the transverse processes. A second assistant can increase efficiency. Another option is 2 surgeons, one for each side of the spine, and the assistant using the aquamanus to pre-treat. Again, the facet joint capsules on the opposite side are pre-treated, and these can then be dissected with very minimal blood loss. Before aquamanus, surgeons had to find each bleeder, bovie it, and the bleeder may reopen. With the aquamanus, this is much easier and more efficient. Excess tissue is removed off of the posterior lamina. We brush the device across the tissue, much like an artist brushing across a canvas. The advantage of the aquamanus is more efficient hemostasis. It covers a much broader area and a much more rapid period of time. It also allows the assistant to pre-treat before the surgical section is carried out. This facilitates a more rapid dissection and exposure of the spine because there's less blood loss from the exposure. A quick summary of the places the device is used. The aquamanus is used to pre-treat the lumbar fascia when reflecting the subcutaneous tissue off of the lumbar fascia. The interval between the spinous processes and the periosteum is also pre-treated to achieve hemostasis for the subperiosteal dissection of the spinous processes, where the muscle is reflected off the spinous process. The lamina is then pre-treated and the dissection is carried out to reflect the paraspinous muscles off the lamina. The facet joint capsules are then pre-treated and the periarticular region, the area superior, lateral, and inferior to the facet joint capsule is pre-treated to allow dissection of the facet joint capsule and exposure of the transverse process in order to minimize blood loss during the exposure of the spine.